Dr. Douglas is a native of Louisville, Kentucky. She received her undergraduate degree from Yale University and her medical degree from the University of Virginia. She then did a pediatrics internship at the University of Cincinnati's Children's Hospital and completed the pediatric residency at the University of Alabama's Children's Hospital. Afterwards, she returned to the University of Virginia for a residency in diagnostic radiology. Dr. Douglas then completed a fellowship in pediatric radiology at the University of Colorado Children's Hospital. She's been certified by both the American Board of Pediatrics and the American Board of Radiology with a certificate of added qualifications in pediatric radiology. And despite all these credentials, I think she secretly wants to be a jockey in the Kentucky Derby. Is that right? Last year at this meeting, Dr. Douglas was sitting in a wheelchair with her leg propped up, having just had surgery on her foot. So it's good to see you on your feet, Margaret, and just please, dancing. Please join me in welcoming Dr. Douglas. She's going to be talking about the child with the bloody stool.
I'm sorry, I hope you're going to be able to hear me. I really appreciate you being here. I think to be at the last lecture, and it's about bloody stools, is really says something about your dedication to advancement of clinical knowledge. Does this go? No. I'm pushing the button underneath. I made the wrong thing. Underneath?
Yeah.
No. There. Whoops. Okay, now make it go back one. Let me take one drink of water. I think that's good, that's better. Bloody stools, it's sort of, my mother and my sister and her husband are here for we did the diabetes walk this morning, and they asked me what I was going to talk about because they were going to come, and I told them and they decided they wouldn't come. So it is sort of a gruesome topic. But it's very important, especially if you're the parents of a child who has bloody stools and you're frightened and don't know what to do. So what we begin, as we do with any clinical problem, is with a clinical evaluation. As radiologists, we're adjuncts to the important job of the primary care physicians in sorting through what's wrong. And as always, we try to get all the information that we can to try to figure out which of the many tests that we can do the child is going to need. So what the pediatrician or a family practitioner or other caregiver may be doing is assessing the character of the bleeding, the volume of the blood loss, and specific signs and symptoms. And then I think often the most important thing, how old the child is. We always say children are not little adults, but little children are not big children, and babies are not toddlers. So by character of the bleeding, I mean, what does it look like? If it's bright red blood coating the stool, that suggests it came from very low in the GI tract, and most likely in a child, maybe an anal fissure, which ironically is scary looking to the mother because it's very recognizable as blood, but it's a minor problem that doesn't need any imaging and is handled in the doctor's office. If you have, on the other hand, blood mixed with a lot of mucus and stool, it has that currant jelly look, that suggests intussusception. And then if it's coming from way high up in the GI tract, by the time it comes out the rectum, I'm sorry, this has gotten worse all day. Really dark blood that suggests melena and maybe from the upper GI tract, possibly like varices or ulcers. And then the volume is another telling thing. If it's a lot of blood, it can be a Mekel's diverticulum. We're going to talk about that in a minute. Ulcers or varices. Minimal bleeding would be more like a fissure or a polyp. And then sometimes you don't even notice it. And finally, the child can be a little anemic, and that can be a polyp. So this is all very helpful for us. The worst thing that ever happened to medicine was to have those ordering forms where the clinical information is shrunk down to a line this long, because we lose a lot. Okay, let's advance. Okay. And then it helps, as always, to know what the patient's input. If it's painless bleeding, that makes us think of a Mekel's or a polyp. If it's paroxysmal pain and an intussusception, if they have splenomegaly and hypertension, that's varices. Okay. But I think in many problems, it's age we're talking about. But you were asking about appendicitis. Does age help? I actually think weight is the way to go. If they're really fat, be careful about the ultrasound. See, they may need a CT. But we wrote it into categories: neonates, 1 month to 2 years, and greater than 2 years. And when you put it out like this, you can see that anal fissures can happen at any age. So that's something to always consider. But then you need to think through the common causes for age. And as I've gotten older, I've realized I used to try to give a talk and cover everything about the subject. You can't do that, and it's just like reading the phone book. So now I like to talk about just sort of the pertinent things that are come up and have a more tailored, specialized workup, and also it's the things that I think are the most interesting. So in this case, it's going to be, what I really want to talk about is intussusception, Mekel's diverticulum, and juvenile polyps. But I hated to not have anything in the first category, so I'm just going to mention something about necrotizing enterocolitis first. Do you think I sound sexy? I hope that's it. So that's what I'm going for. So neonate. Now, since this is a sort of outpatient clinical care, the necrotizing enterocolitis is not going to be so much of an issue because they're usually premature babies that are already in the hospital, that are still in the hospital and have never left. They tend to be, the classic presentation is they're less than 2 kilograms. And what they'll call me in the nursery and say is, baby Jones is starting to have a distended abdomen, and they're looking sluggish, and we're feeding them, but we're getting residuals with every feed. And as it goes on, they'll say, gosh, now they've got bloody stools, they're lethargic, and they're having apnea and bradycardia. So what we do is the plain film is very helpful. In fact, I don't think I've ever done any other imaging for necrotizing enterocolitis. In fact, I wouldn't want to put contrast in somebody that I thought had ischemic bowel. And so what we're doing is we do plain films, and the supine abdomen is always helpful, but we also want to decubit some kind of orthogonal view where if they have free air, you can see it. So you either put them in a decubitous view and shoot across, or you do lying on their back and shoot across. And what we're looking for is they get an ileus first, like how this baby's loops are dilated. And then, is there a laser on this?
Yes.
The big one. And then, is that working?
It's right here. Right there's the laser.
Okay, thank you. And then they start to get these little curvilinear tracts. If they're curvilinear like that, they're subserosal breaks. What causes neck? Nobody knows exactly what causes neck, but it's something, basically it's kind of a hypoxic stress on the bowel, hypoxic ischemic stress on the bowel, and it can damage the mucosal integrity of the bowel, and air is allowed to leak into the wall. If it's curvilinear, it's subserosal. If it's little bubbles and more spotty, cystic looking, it's submucosal. But it basically is telling us that the bowel's been damaged, and then it can track from there up into the portal vein, and we'll see this little air branching pattern, and then the serious sign is that they go on to perforation and pneumoperitoneum. The very difficult thing for the neonatologist and the radiologist is, when do you want to operate? If you go in too soon, all the bowel just looks kind of dusky, and you may take out the wrong part. If you go in too late, then the child may be beyond help. We know that once they have free air and have had a true perforation, they need surgery, but it's trying to figure out at what point do we intervene before that. Certainly, if I see portal venous gas, that's concerning. Okay. All right, so we've given a nod to the neonates, but now we're going to move on to the older children. We're next going to talk about intussusception. That is just, I did pediatrics first and then did radiology, and I've often wished I could go back and do peds again now that I understand the anatomy of what I'm dealing with so much better, because I think it's a huge help in knowing what's wrong, what to look for, and what to do. So an intussusception is when the loop of small bowel intussuscepts into another loop of bowel. If you want to impress your friends or doctors, the loop that goes in is the intussusceptum, and the loop that the receiving loop of bowel is the intussusceptions. And I wish I had a nickel for every time I'd had to correct the spelling in a report. And so that's what an intussusception is. So you can imagine why one of the features would be a big palpable mass, because you got this big wad of bowel that's shoved into another wad. And my record, I think, that I've seen was 4 loops. One shoved into one, shoved into one, shoved into one. That makes a pretty big wad of tissue in somebody's abdomen. Okay. Now, the problem is, you're not just shoving the bowel in, but your bowel, we could open somebody up and you'd see their bowel, it's hanging from the fan of the mesentery, that's the arteries out and the veins back. As you shove that bowel into the other loop, it takes the mesentery with it, along with the blood vessels, so they get kinked off and pinched. So once you get the vascular obstruction, then the bowel's not getting blood supply, you get necrosis of the bowel wall and hemorrhage. That's what leads to the sloughing of the bleeding and the mucus and the current jelly stools. Now, the intussusception itself becomes an obstructing mass. It would be like if I intussuscepted my sleeve and kept doing it, and my bowel keeps trying to fix it, but it can only push in one direction. It just makes it worse and worse and worse. Finally, it can't go, and you end up with a mechanical obstruction. Okay, go ahead. So, the classical presentation. Now, it's always good to know the classical presentation, but it's very frustrating because the children never read the book. You know, they don't know what they're supposed to have. But if you have a young child who comes in with intermittent crampy abdominal pain and separated by periods of relative normalcy, but they're really lethargic, and then a palpable mass and current jelly stools, you have an intussusception. For me, real children have always brought home some of these points. When I'm old enough that when I was a peds resident at Alabama, I'd transferred down from Cincinnati so I could get married. And my second month there, from 11 p.m. to 7 the next day, the Children's ER at Alabama, which served most of Alabama, was staffed by me and an intern. I mean, it was just horrifying. But I remember one night sitting at the desk, and the intern walked by me and said, "I'm so sick of this mom. She's been here 4 times in 24 hours, and she says he's screaming his head off, and he's just lying there." So I was like, "Where's that child?" So we go see him, and sure enough, the Douglas sign is if you go in the room and all 4 extremities are on the table, they're sick. He had an intussusception. He wasn't screaming. And to my poor intern who was way overworked, he was grateful to have a child that was holding still. But he had an intussusception, so when his bowel was pushing, he was in agony, and then his bowel would kind of relax, and he would just lie there. But he had an intussusception, and unfortunately lost some, not a critical amount of bowel, because we didn't recognize it sooner. There are 2 types, 2 subsets within this group of intussusception. More than 90% are ileocolic, meaning the ileum, the small bowel, comes in through the ileocecal valve and herniates into the cecum. As you can imagine, this gets stuck because the peristaltic wave is one direction. It shoves through that ileocecal valve, and it's hard for it to get back. It can't push back. And what it does, though, you know, the cecum is in the right lower quadrant. If this intussuscepts this way, it pushes up and drags up. So as the clinician, you're going to feel that lump, not down in the right lower quadrant. You're going to feel it in the right upper quadrant. That's where it's going to end up. Most of these are idiopathic. And I had a medical student once who said, "What does that mean?" Another medical student said, "Well, you know, it's like, you know, just idiots." No, I don't have to know what it is. It means nobody knows what it is. But the surgeon will report a lot of times that when they go into surgery to reduce it, they'll see hypertrophied lymph nodes down in the terminal ileum. And the thought is that it makes the bowel, you know, sort of heavy or boggy. And instead of being that nice, slippery constant peristalsis, it gets stuck on itself. And a lot of times, if you ask the families, they will have had an antecedent viral illness, not a big major thing, but, oh yeah, he's had a stuffy nose, a low-grade fever, and the thought is maybe the nodes have gotten bigger because of that. Now, there's a totally separate etiology where they can actually have what's called a lead point. Like this section of bowel has a polyp in it, and the peristaltic wave is in one direction, and it finally catches that polyp. It thinks the polyp is a piece of hot dog. So it's trying to push it forward, but in doing so, it invaginates the loop of bowel, and you end up with an intussusception, right? Okay, so if we have that first type, the idiopathic intussusception, they're little kids. And 40% are 3 to 9 months old, 50% are less than a year, and 3/4 are less than 2. It's more often males, I don't know why. And again, the most common symptom is pain, and they have vomiting, and we would forget that sometimes. And intussusception will make you throw up. And then bloody stool from the rectum, and colicky pain, and again, that's the intussusception, and you see where it's starting and then ending up. Okay. Now, if they have an intussusception to a lead point, those are the children at extremes. They're either less than a month or more than 4 years. And we have an example of one here. You can see it nicely on the CT. This is a polyp trapped inside, intussuscepted into another loop of bowel, and here it is at surgical path. And so it's a lead point. So you need to think about that if they seem really young or older. And the common etiologies are Meckel's diverticulum, which we're going to talk about next, duplication cystic polyp. Now, I'm getting so, as I get older, I feel like I have to make a plug for the lowly KUB. It's a great test. It's not very glamorous. You know, it's not expensive. It's not fancy. You don't have to do anything. We've been doing them for 100 years. But it's great. I think it's like getting the big overview of a process. And it's like when you were doing histology, which I hated and was terrible at, so I knew I could never be a pathologist. But when you look at something under the microscope, you always do low power first to get the whole lay of the land. Then you go up to high power. The KUB lets you do that, and you'll see a pattern where they've been vomiting, so they've gotten rid of the proximal air. They've got this big mass, and so they evacuate, they pass out the air in their distal system, and then no more can get through. And then you see the mass. And then there are a couple of really classic signs, the crescent sign, where you can actually see the intussusception within the loop of bowel. So then we're going to go on and look at an example of that. Okay. So here's normal. Medicine is like, radiology is like the rest of medicine. You see 1 million patients, so you recognize normal, so that when abnormal comes in, you realize that they're different. So this is what we like to see. We like to see air in the stomach. It's usually pretty much. You're always eating, swallowing. If you're little, you're screaming. Your stomach gets big. Then you have air scattered in your small bowel. The small bowel, it goes from roughly left to right and top to bottom, so down like this. And then you see air in the cecum, in the colon, which is like a big picture frame around the outside of the abdomen. So that's normal. And air is distributed evenly. It can spread out. It's one big long tube. Now here, it looks totally different. There's little air in the stomach, but there's not much air in the small bowel. There's really no air in this right upper quadrant, and in fact, it looks like there's a mass, which turns out it is the intussusception. And then there's, right in front of leading up to the mass, that small bowel can get kind of dilated, and a lot of times it'll be dragged over to the right side of the abdomen. It isn't really here. But then there's not very much air distally. There's none really in the colon, because the patient has gone ahead and normally evacuated that air, and then nothing else can get through. So if you see this, you feel pretty good that you're dealing with an intussusception. Okay? And what happens there, and then this is the crescent sign. We actually can see the intussusception outlined by the air in the colon. That's nice. Air is a great contrast. And then here it is again. Now sometimes it can be a little tough because, this is fecal material. And sometimes you can get a little bit confused, but this bowel is too dilated, and there's not an even distribution of bowel here. So the KUB is very helpful in saying, okay, I think this is what this is. Now, having said that, I think it's good to do it and it's helpful, now I'm saying why you have to do it. If you think that your patient has an intussusception and you want them to have an enema, we have to do a KUB first to make sure that they don't already have a perforation. Because again, if I knew somebody had a hole in their bowel, I would never want to pump more air through there. I'd be giving them a tension peritoneum or run contrast up through there because it could get out the hole and spill all over their peritoneal cavity. So we're always going to do a plain, even if they come in without one, we're going to do one because we need to, one, get a lay of the land, see what's going on, and two, make sure there's no perforation. I will say, having said all these reasons why it's great, you can have a normal KUB in about up to 25% of patients with intussusception. So a normal KUB in the right clinical setting should not sway you from thinking they've got an intussusception and we should go ahead and pursue this. Okay? The tool that's come into play in my time, in fact, since I came to Raleigh, I've been in a lot of places, since I came to Raleigh, has been ultrasound for intussusception. As a pediatric radiologist, I have loved the use of that. Because imagine you're a little kid who feels terrible, you've got real stomach pain, you're cramping, you're uncomfortable, maybe you've got a colitis, maybe you've got something else, maybe you've got a bad virus, maybe you're dehydrated, but you don't have an intussusception, and then I come in the room to do an air enema on you, put a tube in your bottom and pump your whole colon full of air. It's just horrible. It's horrible for me, horrible for the child, horrible for the parents. And again, the Douglas rule, if I walk in the room and all four extremities are off the table and kicking and waving, I know they're not very sick, I know they don't have it, it's going to be terrible. The ultrasound has taken that away because it really affects our pretest probability, which you mentioned, and I really like that concept. Every test we do, we're always thinking, is it a rule in or a rule out? But if you can do the ultrasound first, we virtually don't do any negative enemas anymore. Because the ultrasound is a very simple test. They just come in for the ultrasound, and the tech just basically sort of lawnmower images up and down and then back and forth to look for an intussusception. And there are multiple studies like this one from the Journal of Pediatric Radiology that shows very sensitive and very specific. Okay, if we see it if it's there, if it's not there, we don't tend to get confused. This was a particularly dramatic one. They're usually not that big. And it shows the intussusceptum surrounded by a kind of a fluid-filled dilated loop of bowel. And it corresponds to this. This is an image from an air enema, but it shows the big intussusceptum here in the colon. You know, we push air in, we're trying to push it back around. Now, the techs were nervous when we first started doing them. They said, well, how? I won't know, you know, what's that weird thing? It can look like a kidney. What do I do? And it's like, if it looks like a kidney, do a count. If there's 3 kidneys, one of them's got to go. So we're okay. Okay, go ahead. So this is what it more typically looks like. And again, you know, we talked about the bowel intussuscepts on itself. So you'll see one squish loop inside another loop. And it's supposed to be like a target sign. And they tend to pop out. You know, you think, at first when we started, we were scared, like, oh, what if we don't see it? I mean, my experience, and one of the body imagers is sitting in the back row, is usually if they have it, it almost sort of seems like it's on a magnet. I mean, it kind of pops out. You don't have to look for it very hard. I had a partner when I was at the University of Colorado who was very nice, but he's very lazy. And so he had like what he called the 20-second rule. He said, if I can't find it in 20 seconds, I leave. But it was amazing that it usually shows up that quickly. We can also use blood flow to assess the Doppler to assess the blood flow to the loop. Okay, so go ahead. So what are we going to do? We usually now try to do an air enema. We like that for a lot of reasons. We put a tube in their bottom, but instead of hooking it up to a bag of contrast up on a pole, you know, when I first started training, it would be barium in a bag, and you just open up the bag, and through the tube, the barium runs it in under hydrostatic pressure. It just runs in and hopefully hits the enema and then pushes it back. Now with air, we put a tube in their bottom, but it's hooked up to this device that a radiologist invented. It's like the manometer, handheld manometer from a blood pressure cuff, and you push the air actively back around. It's more controlled because you can look at the dial. You're not supposed to exceed 120 millimeters of mercury, and you push it back around, and I think you can kind of get a better grip on it, and the success rate is higher. The perforation rate is just a tiny bit higher. It's, you know, like maybe 2% at most compared to 1%. But the thought is that if you did blow a hole in the bowel, which you could with any kind of contrast, the hole is smaller and the morbidity is less. They did an experiment that was an elegant experiment, unless you were a baby pig, where they took baby pigs and put a combination of fecal material and air, fecal material and barium, or fecal material and water-soluble contrast in their peritoneal cavities, and they do the best with just air. So this, if they're coming to us at Wake Radiology, this is what we're going to be doing, an air enema. The time you wouldn't do air is if they already had so much air in their small bowel that it was going to be confusing. Now, the critical thing is that because we can cause a perforation, a surgeon always has to be aware before we do the test. Okay. And then, okay, all right, so let's see, go ahead. Oh, sorry. Okay, go back one. I'm sorry, I lost my train of thought. So again, here's some samples of the enema. This again, we see this child come in, this paucity of gas in the right upper quadrant, little gas proximally or distally. We put the tube in their bottom, pump air back around. We see the intussusception, we're able to push it back through. Next case. And this is what it looks like. This is the one I showed you before. No gas here. And then once we've done the enema, here's the Foley catheter with a balloon. It's inflated back around, pop the intussusception back through the ileocecal valve, and then you get a sudden rush of air back and see all these small bowel loops are filled with air now that weren't before, and we've reduced it. It's actually kind of fun because as a radiologist, you don't get much opportunity to fix anything. So this is about the only thing we can fix. Only fruit baskets I've ever gotten have been from the parents of children that had intussusception. One of them said, boy, when I talk to my real doctor, I'm going to tell him how well you did. So, so here's the scenario we like to see. This is a 10-month-old child who came in with crampy pain. We did the doctor ordered a KUB. We see that paucity of gas in the right upper quadrant. Not much proximal area. He had been vomiting. He's evacuated a lot of it. We feel pretty comfortable that he's got an intussusception. We don't see any free air. We don't see any reason. And we get the clinical input. Have they had so much vomiting that they're not hemodynamically stable? We notify a surgeon. The surgeons, it's not fair to cause a problem you can't fix without already notifying the person that's going to have to help you. If I caused a perforation, and I knock on wood every time I say that because I haven't yet, I think sooner or later I probably will. If I caused a perforation, I would have to call a surgeon and say, you've got to come fix this. So the surgeons don't want us to do these enemas where they can't fix it. When I first came, some of my group was trying really hard to be really efficient. They said, please don't do these at Smithfield because we're not, I'm talking about our pediatric surgeons. We're not at Smithfield. Don't do it in an office. We're not at your office. You got to do it. So if your pretest probability is high and you think they've got it, even if you want to do an ultrasound first, then you go to the hospital because where they can get everything done. If your pretest probability is you're not really sure, well, what could it be? Is it an intussusception, yes or no? The ultrasound can be done anywhere. It's great. It's a great way to rule out an intussusception. Okay, and then you do it in a facility. So, and this is one, there was one of my older partners who was using contrast, I was not familiar with air, pushed the contrast back through the enema, you encounter the intussusception, saw it here. He was able to reduce it. If he hadn't been able to, if it had just stayed like this, the child would have gone from the radiology suite up to surgery to have it reduced. Okay? Okay, so we talked about that. Now, we're going to talk next about Meckel's diverticulum, which I think is one of the most interesting things, anatomic things in pediatrics. First of all, what is it? Well, it's the most common congenital GI malformation. Here's a loop of ileum, and here's the Meckel's diverticulum coming off of that. It's found in about 2% of routine autopsies, so you can have it and it never bothers you. It's a true diverticulum, meaning all the all the 4 layers of the bowel come out like this. It's found usually 60 to 70 centimeters from the ileocecal valve. So you see it here. It's more of it's coming off the distal ileum. So you got all these loops of bowel, and then you got this little out pouching. Okay? And where did it come from? The more to really understand anatomy, I think you always end up having to roll back to the embryology. But here's a very early embryo. And here's the primitive stomach, and then the intestine. And there's this vitelline duct that goes out to the yolk sac, and it's through what's going to be the umbilicus. It's widely patent, but then usually disappears by 6 to 9 weeks. Okay? So here are the things, anything in your body, there's a way it should work, and then there's a way it can work. So here are all the options. Here are all the ways, that 50 ways to leave your lover, 50 ways to have your omphallomesenteric duct messed up. This is what's normally supposed to happen. Here's your ileum, the duct closes, here's your abdominal wall with your belly button, they're totally separate, great. It doesn't totally go away, it leaves like this outpatching, that's a Meckel's diverticulum, that's B, that's the most common. It can close but leave a fibrous band connecting it. It can close at both ends and trap a little cyst in between, or it can stay open and the mom will say, I know this sounds crazy, but I swear it looks like there's stool coming out the baby's belly button. There really can be. Or the whole thing can prolapse or herniate out through the belly button. Okay. Now we're talking about bloody stools, but I just have to, I think I really like Meckel's diverticulum. I think it's really interesting. So I'm just going to have a quick aside about this. This is a drawing. Pretend this is just the little fibrous band residual. Here's the bowel. Here's the spine. This is a lateral view of a baby. So we just have this little fibrous duct. It's in there. It's not bothering you. You don't even know you have it. Well, another loop of bowel can wrap around this and cause a close of volvulus. Or if you have the little duct, now it can't be attached, but if you have the little duct, it can invaginate and then act as a lead point for intussusception. So this is a real case we had. And this is where I was talking about the value of the plain film. This baby was sent over from the ER. Baby's vomiting, sick, we don't know what's going on. They wanted an ultrasound for pyloric stenosis and an ultrasound for intussusception. Those are both very good but very binary exams. Yes or no, and they give strong answers. So we did the ultrasound for pyloric stenosis, no pyloric stenosis. We did the ultrasound for intussusception, no intussusception. Well, we still have this sick baby that we don't know what's wrong. So I said, could we order the cheap KUB? And we see that the baby's got multiple elongated, dilated loops of bowel, which are consistent with the distal small bowel obstruction. Well, this baby's like 6 or 8 months old and has been perfectly fine. No other problem, no other symptoms until that day the baby'd gotten really sick. So we first did a BE and that looked normal because if you got a whole lot of loops, start from the bottom. You don't have many loops, start from the top. And since that looked normal, we did a quick limited upper GI from the top and showed no malrotation because you didn't have a true volvulus for malrotation. But we see this normal duodenum and then all these big loops of small bowel. So we know between the normal upper small bowel and the normal colon, there are big loops that are trapped. And it turned out the baby had one of those fibrous bands from the closed vitelline duct. There's just a band, and loops of bowel were wrapped around it. And when they went and opened the baby up and untwisted it and clipped the band, the baby was fine. So we're talking about Meckel's diverticulum presenting not as an obstruction or an intussusception, but as rectal bleeding. Well, what happens here is about 25, up to 25%, it varies depending on who you read, of these little Meckel's diverticulum, and this again is the colon, the small bowel, can contain gastric tissue or sometimes pancreatic tissue. If it has gastric tissue, it's secreting acid. So you end up with, it's putting acid out. And I've heard that where it actually irritates the most is not the Mekel's itself, because it's lined with parietal, so it's used to acid, it's stomach tissue, but the opposite wall. And see how the ileum right around it is very inflamed and irritated because it's just getting acid dumped into it all the time. You can get bleeding, ulceration, or perforation. So the classic presentation of a Mekel's is painless rectal bleeding in a 2-year-old, males more than females. The bleeding is intermittent. I mean, they basically got an ulcer. But it can be very severe. I mean, it can be scary. The rectal blood can be maroon, meaning it's been coming through slowly and had some time to be broken out, or it can be bright red. And sometimes it can hurt because they can have inflammation from the ulceration. So what do we do? Well, we do a nuclear medicine test called a Mekel scan. This is one time, and you saw that little Mekel's. Imagine putting barium in all those loops of small bowel and then saying, where's the Mekel's? It's like, I don't know. It's like, where's Waldo? But, if Waldo looked like everybody else. So we need to do and the reason I'm saying that is if you do a small bowel first, we have to wait a long time to get them all cleared out before we can do the nuclear medicine test. So if you really think it might be a Mekel's, do the Mekel scan. Now, again, the Mekel scan is a binary test. It's a yes-no, but it's a good yes-no. I mean, it gives you a very specific answer. What we do is we give them technetium, none, and then protectinate, and that goes to, nuclear medicine is called unclear medicine because the pictures are fuzzy, but it's very elegant physiologically. So we're saying, well, I want to see if there's ectopic gastric mucosa. Not all Mekel's have ectopic gastric mucosa, but the ones with the gastric mucosa are the ones that bleed. So I want to see if there's ectopic gastric mucosa anywhere in this child's body, specifically a Mekel's. So I'm going to try to find something which will go to gastric mucosa. So then it'll show the stomach, which we know has gastric mucosa, and then we want to see if there's any abnormal uptake anywhere else. Now it's being filtered, it's in the bloodstream, so it's going through the other tissue like liver, spleen, kidneys, and then a little bit excretes out in the bladder. But on this one, we don't see anything, okay? I will say before we do that, we prep them. Our preferred prep is cimetidine, and I'm telling you all this because we start it the day before the exam. So, they can't come to the exam, and then we can't give it to them the day before the exam. So you need to know we do cimetidine. There is the updated pediatric nuclear medicine protocols from 2002 talk about you can use ranitidine. We can give one dose about an hour before the exam. It doesn't work quite as well, so if you think of it, we prefer it if you do the cimetidine. Both are histamine H2 receptor antagonists. They block the production of gastric acid. So what we're hoping is the protectinate will go to the parietal cells and then it sits there. It doesn't excrete out because the H2 blocker is holding it in place, which makes the test easier to read. So here's what we're looking for. Here's a positive Mekel scan. So here's all the uptake in the stomach, which we expected. We've given them cimetidine successfully, so it's not already dumping out. The acid's already dumping out into the small bowel and confusing us. We see pretty clean activity in the stomach. And then, of course, it's going through the vascular blood supply, going through the organs, and being secreted by the bladder, which is normal. But then we see this persistent hot focus, and that's the Mekel's diverticulum that has gastric tissue in it. Now, so your patients come in, they have to get an IV, they have to lie still on a narrow table. We have VCRs that show, the movie of your choice. But we have to put a catheter in their bladder. And some people call me and say, it seems so mean, why they put a catheter in their bladder? Well, you can imagine, this loop of bowel is not fixed. And I've seen 2 misses where the diverticulum's down behind the bladder. If the bladder's full, you don't see it. So we put the catheter in their bladder so that they're constantly draining the activity out. Okay? The other thing we do is, we've got a lot smarter about doing multiple views. Like even if the bladder's kind of full, you can get a lateral. So you're behind, and I have seen that once. We did that in Alabama. We put them laterally, and all of a sudden it looked like there were 2 bladders. It was actually the bladder and the Mekel's behind. So that's another way to do it. So this one's negative. Just see the stomach and then the bladder where it's excreting. And then here's the stomach. And I think they were marking the child's belly button. This is a stick with radionuclide on it that they know about. But then this persistent other focus is the Mekel's diverticulum. Now the last thing we're going to talk about is juvenile polyps. And I'm sorry, I'm a little bit behind. Polyps are sort of, I remember Pete thinking, oh my gosh, we're talking about polyps, I can't keep all these straight. They're basically 4 categories. Isolated benign juvenile polyps, inherited syndromes, polyposis, inherited both hamartomatous and adenomatous, and then non-inherited polyposis. Now, see again, I'm old enough, we don't have to talk about all of these. We're going to talk about what we want to talk about. Okay, go ahead. And the most common ones we see in children are juvenile polyps, juvenile polyposis, and Peutz-Jeghers. Okay, go ahead. So a juvenile polyp is the most common childhood tumor of the colon. And look how this looks. It's pedunculated on a stalk. It's got a big round end. It's not really a true neoplasm. They're large, cystically dilated glands. They don't have much smooth muscle over them, and it's easily ulcerated and worn off, and they bleed. They can tend to be big, 1 to 5 centimeters. Okay. The classic presentation is an older child. Did I do that? Sorry. 2 to 10 years, between 2 and 10. The rectal bleeding is painless. They're not having any symptoms. It's intermittent. It's rarely profuse, but they can develop anemia over time. And where we find it most likely, the most common is in the rectosigmoid colon. And if you have 5 or less, they're considered isolated juvenile polyps, just benign lesions. If now polyposis, the second thing on that list, you have 6 or more in the colon or elsewhere in the GI tract. They tend to have a family history. It may be, in some cases, it may be an autosomal dominant transmission, and they're at more risk for GI neoplasms. Okay. And then the other thing is Peutz-Jeghers syndrome. This is the most common polyposis syndrome in kids. And I had a great case of this. You learn from your patients. This little boy came in. He had the classic appearance of intussusception, vomiting, rectal bleeding, intermittent crampy pain. So we did a BE and found nothing. It was and I was young. I was, I think, a fellow. I said, well, he doesn't have intussusception, but he sure looked like it. He looked sick, so he got admitted. And then the next day, another film, and I thought, gosh, it looks like he's got a mass in the middle there. So we did an ultrasound, and he had, he was my record of the intussusception, ilio intussusception. I didn't know what it was at first because it was just gigantic. I mean, it was just all over the place. So he did have an intussusception, but it was a small bowel. So the regular enema, which looks at your colon, wouldn't show it. So we realized he's 6 years old. So he's too old. He's actually a good summary of what I've been talking about. He's too old for the idiopathic intussusception, so we think, man, he's probably got a lead point. So he's going to the OR, and they're going to pull it out, and they're thinking, well, we're probably going to find a lead point in here because he's 6. And I went to the OR to see, and we're standing there. I said, he's probably going to have a lead point. And the surgeon said, yeah, I bet he is. The anesthesiologist says, hey, he's got freckles on his lips. So, and they, the Peutz-Jeghers kids get pigmentation of their mucosa, especially in the buccal area. So he had a small bowel intussusception. Okay. If we want to look at the colon for polyps, remember I showed you that path slide of the polyp? It's a round ball. Fecal material looks just like that. So they have to be, and this is really why I picked this topic for this slide. They have to be cleaned out. They have to be. That is a very frustrating thing. I mean, I bet if I polled all of you, how would you clean out a patient for an air contrast BE? I bet we'd get as many different answers as there are people in the room. I've been in many different hospitals, and a lot of times it doesn't work. And it's gotten to where it's not tenable. Because the family will come in, they've done half of one thing, half of another, and they're not cleaned out. They're going to have to come back. The father's going to have to take another day off from work. And I'm telling you, the last year, I've told some fathers, you're going to have to come back another day. They've almost had tears in their eyes. People can't afford to miss another day of work just because we didn't get them cleaned out the first time. So we have to do it, and it starts the day before. And we have a protocol now, and I think it's in the handout. Yeah, I hope they told me they were going to put it in the handout about how to clean them out. So it's more detailed than this. But take it home, put it on the wall. I should have put a picture of, I don't know, the Yankees or something at the top of it so people would want to hang it up. But this is adapted from the protocol that the gastroenterologists at Chapel Hill used to clean people out. And actually my first exposure to it was my daughter had to have an endoscopy, and she had to do this prep. And I can speak from my sample of one, N of 1, it works. So what they say is they have to be having daily regular soft stools. So if they're not, you start milk of magnesia, and their dosing guidelines on that handout.
It's actually not in there because it had our name on it, but it is found on our website.
Oh, okay. So, and that website is?
wakerad.com.
wakerad.com. And where would you get it? Under what?
Under patient information preparation.
Patient information preparation, okay? Because we put a lot of time into this, and I'd left some of the specifics out. The nice thing about the prep, it's not the long 3-day ordeal that it was when I was a resident. Now, they can eat until 11 o'clock of the day before the test. After that, they should just have clear liquids, and that means, something you can basically see through. We suggest they don't have red or purple things because they can look like blood. It's the wrong color, but like ginger ale, Jell-O. And on that list, there's a very complete list that I copied from the Chapel Hill people. Then they take 3 doses of magnesium citrate that afternoon, I think at 11, 2, and 5. And after the third one, if they're not having, by that evening, if they're not having clear watery stools, they should have like 1 square of chocolate X-lax. Now, what I learned from helping my own daughter go through this, because she was, 8 or something, the mag citrate is not very pleasant, but don't dilute it. The first dose I gave her, I diluted it in like 8 ounces of liquid. Well, then I'm struggling with trying to get her to drink 8 ounces of something she didn't like. I would have been much better off with a small amount and then putting like that Crystal Light powder or Kool-Aid powder. Just put something in the small volume, and the next 2 doses, we did a lot better. The square of chocolate X-lax, she was very happy to eat, and I actually added onto our prep on the website, put the candy away, put it away, because she was saying she wanted some more of that candy. I'm like, well, no, you don't. So, because see, here's what it looks like. This child was prepped. We put the air in, then we put the contrast in, and we see this filling defect. Now, if I just had that one picture, there's no way, it'd be very hard for me to swear, is that fecal material or is that a polyp? We saw it on another view, lateral, and it persisted, so it was a polyp. They took it out and we did well. And this is another one. I've got the tube in the child's bottom, and we're putting in air first, and the air is great contrast, cheap, readily available. It surrounds the polyp, and when we came back later with the contrast, we see it again. So, but it's, if you haven't cleaned them out, you can't tell. Okay. So, in conclusion, there are many causes of rectal bleeding. Clinical findings will direct the patient towards the correct imaging. It is constantly a back and forth, close communication. We have a phone number now. Now that we're a division, I got promoted. You stay in one place long enough, they finally have to promote you. I have 3 new young, really smart partners. But we have a number where you can call. I used to be embarrassed when I was a peds resident because I couldn't remember, do I want an upper GI or do I want a barium swallow? I realize now the radiologist could have cared less what I called it. The radiologist wanted me to call and say, here's my patient's problem, here's my question, you help me figure out what to do. And once we get the information, depending on where we're going, ultrasound is a very sensitive test for the diagnosis of intussusception. Mekel's diverticulum is best seen with nuclear medicine, and you must prep patients adequately to get a diagnostic quality enema for juvenile polyps. Thank you. Okay, if you have questions or if you'd like to hear more details about the football game from last night, I'll be here available. I did want to just make a couple of comments. Brent did such a beautiful job of answering the questions, but Brent's married, so he knows women can never resist having the last word. In terms of head injury, we had hoped, originally they thought, well, if we get skull films and we don't see a fracture, we're fine. That's been well proven that doesn't work. If you're worried about it, a lot more of it's the clinical symptoms. If they've had loss of consciousness, if you're concerned, he's exactly right. You have to do a head CT. The nice thing is the head CT doesn't need contrast. In fact, contrast is confusing because contrast is bright white and acute hemorrhage is bright white. So it's just a non-enhanced head CT, one-time pass-through. In terms of appendicitis, I think the difficult thing, I've been on a couple of panels about this, and I don't think there's one uniform answer. And Dr. Haugen, who actually did published some work on appendicitis when he was at Duke, is sitting up there, so I'm very careful about what I say. But I think he would agree with me that part of the problem is ultrasound can be a very sensitive test, but it is very operator dependent. And when I was on that panel, I was with pediatric radiologists from Duke and Chapel Hill, and Dr. Fresh said that we can't have one policy because it depends so much on who's doing the ultrasound and what time of day it is. If it's 10 o'clock in the morning on a weekday and you've got your A team of technologists and your A team of, the doctors that do it all the time there, ultrasound can be pretty good. If it's people that are having to fill in or the mammographers on call or people that don't usually do it, it's a very different thing. In terms of kids, it's body mass really matters more than age. I did a 6'2" football player the other day. He was a thin kid. And I could see his appendix was kind of hiding up under his iliac crest. But just the fact that he was hanging off the table didn't mean we couldn't do the ultrasound. If I see a short, round 8-year-old, it can be very hard because the beam attenuates so much as you go in deep. So, okay. Any other questions? Oh, yeah.
What's the success rate for the intussusception, the reduction in that? What's your success rate for that?
I don't know. We haven't looked at it. I haven't looked at that. It's interesting. I think that's a little bit operator dependent too, how many you've done and how comfortable you are just pushing. I guess for me personally, I can think of 2 I couldn't reduce in the last 10 years. That's, again, not a legitimate sample. All right, thank you.
Wait, I have 2 questions.
Yeah.
Of the ones that you do reduce, how many are recurrent?
That's a very good question. What Dr. Van Arthos is asking is how many are recurrent. Brent, I don't know the statistic on that.
I quote like 5% risk of recurrence.
And it tends to be in the first 24 to 48 hours. Just having one recurrence alone, the surgeons are pretty comfortable that in the idiopathic age range, that 3 to 9 month old, 3 to under 2 years, you can have another idiopathic one. I think if they've had a third one, then it becomes time to start thinking, what is it? We had, the last one we had that had a third one, the parents said, we can't stand this anymore. When they explored him, he did have a pancreatic rest and a zillion that was catching and causing the intussusception. But just a recurrence alone doesn't mean it's not idiopathic.
You can do the air contrast again. That's
Yeah,
the thing,
right.
you know.
Yeah, we did.
Come back
That's
there
right.
later, we'll reduce it again.
I think that's honestly the reason a lot of children, once they're reduced, they're kept in the hospital overnight in case it recurs. Because it's most likely to recur while it's still all swollen and boggy down there.
The second question is, you mentioned the consequences of ectopic gastric tissue in Mekel's. Are there any similar consequences for the pancreatic?
Well, I've wondered that child that had the recurrent intussusception over and over again, and they said it was distal ileum. I've wondered if that was a little pancreatic rest in like a Mekel's. And that because they said it was a small nubbin of tissue. I think they can, some of them can secrete enzymes that are corrosive too. But a lot of times it's more just the mass effect.
You want to invite the other
Yeah.
balances back down and
Couple of things. Yeah. You're welcome. Don't go away.